The updated analysis of KEYNOTE-021 with 5 additional months of follow-up confirmed the data that we saw at ESMO in 2016 and was published in Lancet Oncology in 2016. With the additional follow-up, we have seen confirmation of the superior response rate, which was the primary endpoint of the study, as well as superior progression-free survival for patients treated with combination of chemotherapy and pembrolizumab. We have also seen evidence of early separation of the curves for overall survival with a hazard ratio of 0.69. However, this is not the primary endpoint of this study, and the data are still maturing.
My personal experience with that combination has been largely limited to the clinical trial. Since the recent approval in May of 2017, I have had the opportunity to start 2 patients on the regimen, but it's way too soon to actually gauge therapeutic benefit. To date, both on trial and off trial, it's been an extremely well-tolerated regimen, with most of the toxicity, to be frank, driven by the PD-1 inhibitor. Again, we see arthralgias, sometimes rash, occasionally pruritus without rash, rarely diarrhea, and in my own personal experience, I've observed a fair amount of hypothyroidism, which can sometimes come on fairly abruptly, where TSH is normal 1 week and then 3 weeks later has jumped up to 80 or 100, and the patients feel it. They're quite fatigued, but fortunately we can fix it very readily with levothyroxine, with essentially replacement therapy.
Well, I would, anyone who's PD-L1 high, greater than 50% would get immunotherapy pembrolizumab alone. Anyone who's low would be a candidate for this combination of carboplatin, pemetrexed, and pembrolizumab. Certainly if there was a trial of 2 IO agents or something else going on, a vaccine, I might consider that first. But I think that this is a combination that can be used frontline or, by the way, second line. I think it particularly might have some activity in those patients who are PD-L1 negative or low. So it's probably doing something to kill tumor cells, activate neoantigen, to stimulate the immune response, probably having an effect on the immune microenvironment to sort of rev things up, but definitely something that is worth exploring and considering and discussing with patients.
The clinical trial data suggests that patients can benefit from this therapy irrespective of their PD-L1 status. For patients with high PD-L1 expression defined as 50% or more, I think there's going to be a dilemma in my practice on whether I'm going to be using single agent pembrolizumab for these patients versus the combination therapy. Certainly excluded from this consideration would be patients that would be poor candidates for chemotherapy, either due to comorbid disease or declining performance status. I will present the options and the data to my patients, and we will be making decisions together.
IO use and maintenance, I think, is going to be very promising. We already know from a press release not too long ago that durvalumab, a PD-L1 antibody in stage 3 lung cancer, meaning lung cancer that's locally advanced, either ipsilateral or contralateral lymph node involvement, there was an improvement in progression-free survival for durvalumab, the PD-L1 inhibitor, versus placebo. Data are not released yet, but we know a trial was stopped early, which suggests that it was a compelling result. So I think these drugs, if they're active, the best thing to do now would be to move them up and use them a little earlier. Why wait for disease to progress? Use them earlier. Give them time to have their effect. So I think we're going to see them moved up to maintenance. I think we'll see them move to adjuvant therapy. Neoadjuvant therapy trials are already ongoing, and maybe someday even for chemoprevention settings.
Based on the clinical trial results from study 21G, the patients received 4 cycles of chemotherapy in combination with pembrolizumab before switching to maintenance therapy. The dose of pembrolizumab used was a flat dose of 200 milligrams every 3 weeks. The clinical trial was based on use of pembrolizumab for 2 years after completion of chemotherapy in combination with pembrolizumab. We do not know yet what is the optimal duration of maintenance therapy in this setting, and that clinical question should be answered in a clinical trial.